Good afternoon, everyone. My name is Tammy Geltmaker, and I'm a Program Director for QSource. On behalf of the Indiana Department of Health and QSource, I'd like to welcome you to the May 4th Public Health Update webinar. During today's session of our COVID-19 Moving from Pandemic to Endemic series, our speakers will provide COVID-19 updates, continue their discussion on emergency planning and preparedness, and share information on other emerging epidemiological issues. Our agenda for today includes opening remarks, our featured presentation, an opportunity for question and answer, as well as some closing remarks. As you may know, QSource is the Quality Innovation Network Quality Improvement Organization, or QINQIO for Indiana. We convene, teach, and inform healthcare providers, engage and empower patients, and inspire the entire healthcare continuum by sharing knowledge and spreading best practices. Thank you for taking time to join us. We appreciate all that you do to improve quality and achieve better outcomes in health and healthcare, and at lower costs for the patients and communities that we serve. As referenced earlier, today's Q&A session is one of many monthly webinars that will be hosted by QSource. Each session is made available for on-demand learning to share with your peers. Today's presentation will be made available as well. Before we begin, I want to run through just a few housekeeping items. We have your lines and your microphones muted at this time. We will be opening both during today's webinar when the Q&A portion begins. In addition, we do have the question and chat feature. That feature is located on the right side of your screen. Don Gettinger will be monitoring the chat feature as we move through the presentation today. So if you have a question or a comment, you can post it in the chat. We will respond to you either in the chat or on the call. We do encourage you to please monitor the chat function frequently for information, resources, and answers to your questions. Before we begin today's presentation, we do have a polling question for you. In which setting do you work? Ambulatory care, community-based, government, home health, hospital, long-term care, pharmacy, or other? Please select one. If you work in another setting, please feel welcome to enter that information into the chat. We'll give you just a few seconds to take the poll. The poll is now closed. Thank you all for participating in the polling question. The results of our poll show that 53% of our attendees are from the long-term care setting, 13% are from hospital, 13% are from community-based, and then we also have some that are other. Thank you. It is now my pleasure to introduce today's speakers from the Indiana Department of Health. Pam Pantonis, Deputy Health Commissioner and State Epidemiologist, Office of the State Health Commissioner, and Dr. Shirisha Vupalanchi, Medical Director, Office of the Chief Medical Officer. Ms. Pantonis and Dr. Vupalanchi are also going to be joined today by a special guest, Jeremy Turner, Director, Division of HIV, STD, and Viral Hepatitis. At this time, I'd like to turn it over to our speakers.
Good afternoon, and thank you so much for joining us today. I'm Pam Pantonis, and it's a pleasure to be able to speak with you. We wanted to share with you some public health updates regarding COVID-19, and then also what you had shared with us earlier that you wanted to hear more about what is happening with HIV and viral hepatitis, sexually transmitted diseases. And Jeremy is here to cover that with you today. And all three of us will be available at the end of the presentations today to answer your questions. So with that, we will go ahead and get started with our COVID-19 update. And starting off with pediatric vaccine updates, and a lot of this coming through just in the past few days, and a lot now coming in June that we are hearing from the national level. So on Thursday of last week, Moderna filed for emergency use authorization from the FDA for its COVID 19 vaccine in young children ages 6 months to under 2 years, and then 2 years to under 6 years of age. So, two pediatric cohorts based on the results from their clinical trials. Trials for children above age 6 or older than age 6 through up to 18 are still in clinical trial at this point. That request is supported by results of a clinical trial that involved 6,700 children that showed that two 25 microgram doses of the Moderna mRNA vaccine produced a similar immune response in young children as the two 100 microgram primary doses for adults ages 18 to 25 years. So, having that age appropriate lower dose still produced a very similar immune response as what was seen in the adult trials. So very promising. Vaccine efficacy remained significant at 51% for ages 6 months to under 2, and 37% for ages 2 to under 6. This is overall for infection. So I do want to underscore that the vaccines are very good, even higher, much higher at preventing the serious infection and serious outcomes such as hospitalizations and deaths. So maybe those numbers might seem low, given some of the numbers that we've seen before, but keep in mind this is for infection. And those numbers are going to be much higher for the severe infection and for the serious outcomes that can result. That EUA submission was expected to be complete this past week into this week. And Moderna is also, again, currently studying their clinical trials for booster doses for all of their pediatric cohorts. And you can check out the latest at the link shown on your slide. Next slide. Pfizer also last Tuesday, a week ago yesterday, submitted an EUA application for a 10 microgram booster dose for ages 5 to 11. Studies show that antibody levels 6 months after that booster dose are about 36-fold higher than after the second primary dose against Omicron, and six-fold higher against the original SARS-CoV-2 strain. So seeing that booster dose for ages 5 to 11, again, very effective if we're looking at antibody levels. So Pfizer has submitted that EUA application last week for that consideration. Data from that study again demonstrated a strong immune response and no new safety signals, which is important given some of the earlier concerns with myocarditis. But that does not appear to be an issue based on the data from these clinical trials. Again, you can check out the link shown on your slide from the Pfizer news release for more information. Next slide. So, with all of this, FDA has set a tentative meeting schedule in June for their Vaccines and Related Biological Products Advisory Committee, or VRBPAC. On June 7th, the FDA intends to convene the VRBPAC to discuss an EUA request for another COVID 19 vaccine, this one manufactured by Novavax, to prevent COVID 19 in individuals 18 years of age and older. So, Novavax has been in distribution for several months, starting in 2021, but really has been used in other countries, in Europe, I believe Canada, Asia, Africa. So, now bringing it to the States to be able to use for adults 18 years of age and older. This is a two-dose series. And then VRBPAC will study the data on June 7th. And these are hold dates. They are subject to change if the need arises. Other meetings have been tentatively scheduled for June 8th, 21st, and 22nd for the VRBPAC to discuss updates to what we just heard, the Moderna and the Pfizer EUAs for their vaccines for younger populations. So the Moderna for under 18, and then Pfizer booster 5 to 11. As those sponsors complete their submission and the VRBPAC reviews the data, it will provide additional details on that schedule based on each EUA request. But for now, those hold dates are June 8th, 21st, and 22nd. On June 28th, FDA plans to convene the VRBPAC to discuss whether the SARS-CoV-2 strain composition of the vaccines should be modified for the coming fall, and if so, what those strains should be. This is a follow-up to the April 6th VRBPAC meeting that discussed the overall framework for COVID-19 vaccine booster doses and the strain composition to further meet public health needs. So now they're going to drill down, expected June 28th, to decide, okay, what are we really doing for the fall? What kinds of boosters do we need to change up the strain? Do we need to include Omicron? All those kinds of questions. We'll be looking at vaccine data and then infection data that we're seeing right now across the country. And you can check out more information at the link shown on your slide. Next slide. So our dashboard updates, we do have some additional features. The COVID-19 vaccination dashboard. Thank you, Don, for posting that link there in the chat. We do have some updated features regarding breakthrough infections and vaccination data. When you go to that link, you will see the breakthrough. If you click on the breakthrough infection tab, you will see breakthrough cases by age group. You'll see kind of the temporal or time distribution of cases, vaccination rates, and then also you may remember the zip code map of Indiana showing vaccine uptake. And you can see there the map is much more blue and gray than the red and orange, which show lower areas of uptake. So we have some better organization of our data and granularity of data. Next slide. And then also showing some different data points with our COVID-19 at a glance dashboard. So this is all of the case data, again, at coronavirus.in.gov. You can see where we've moved some of the features around so that it's a lot more easily visualized, including our case counts, total counts, 7-day averages, and then timelines as well. You can also look at demographics. You can drill down by district on the right-hand side and even by county, where we now have more granular county data to help local officials and elected officials making decisions that for control measures or the kind of projected where to from here with COVID-19 cases. Next slide. With treatment updates, just a reminder that sotrovimab is not authorized and is not being distributed in Indiana. Sotrovimab has been shown to not be as effective against the BA.2 variant. So FDA has pulled that back from distribution, and it is no longer authorized to be distributed. So current monoclonal antibody infusion sites should stop administration of sotrovimab and instead use bebtelovimab, which is a monoclonal antibody treatment or therapy that is shown to be effective against the BA.2 variant, which is currently, and I'll underscore currently, the dominant variant in Indiana as well as in the US. We have updated our treatment availability map to reflect the sites that currently offer bebtelovimab monoclonal antibody treatment. Those are denoted as the green circles with the white cross shown at the link on your slide. Next slide. FDA's been busy. They have also expanded the approval of COVID-19 treatment remdesivir, or under the trade name Veklury, now to include pediatric patients all the way down to 28 days of age and older, weighing at least 3 kilos or about 7 pounds that have tested positive through viral testing. These patients who are hospitalized or maybe they're not hospitalized, but they have mild to moderate COVID-19 and they're at high risk for progression to severe disease and outcomes. So we used to have remdesivir down, I think, to offered to about age 12. That has now been approved for the wide spectrum of pediatric patients down to 28 days of age and weighing at least about 7 pounds at a minimum. Previously, again, only showing was approved for 12 years of age and up. You can check that out at the link shown on your slide as well. Next slide. So one question we get a lot is, where do we stand with cases now? You can see the distribution of new cases by county. This is as of, I believe, Monday morning. And we are seeing, and we'll, full transparency, seeing a slight uptick now in cases in Indiana. This is not a rapid rise. This is not the Omicron Space Needle spike that we saw in early January, but rather it's a slow, kind of gradual increase in cases due to that BA.2 variant, which is more transmissible than the BA.1 variant. Nationally, hearing on national calls that cases are increasing by about 34% week over week compared to the last 7 days. Hospitalizations up nationally about 10% or so compared to the previous week. We are not seeing hospitalizations at this point increasing in Indiana, but we are seeing cases now starting to on that gradual increasing trajectory. Next slide. But very fortunately, no deaths. So again, for the past several weeks, no 7 day average of deaths by county still being at zero. Very happy to see that. Vaccinations by age group, we're up around 60% overall, just slightly below. And again, really wanting to make strides in our vaccination. Next slide. As we know, that is the best preventive tool that we have. Boosters by age group, again, about 57% of eligible age groups overall having received at least one booster. Again, really trying to make sure we get those younger age groups as they are authorized to get boosted. Next slide. So some other updates, CDC published last week in its Morbidity and Mortality Weekly Report that COVID-19 was again the third leading cause of death in the US in 2021 behind heart disease and cancer. So 2020 marked a very big change in that an infectious disease was such a top leading cause of death. And we've seen this now 2 years running, with 2021 also showing that COVID-19, that third leading cause of death. However, in 2021, COVID-19 deaths increased by nearly 20%, presumably due to the more severe Delta variant that surfaced late last summer and fall. Biden administration has now announced that it will double the number of locations where COVID-19 oral antiviral treatments like Paxlovid and Molnupiravir are available. Currently, there are 20,000 sites across the US that offer Paxlovid and Molnupiravir, and the administration is expecting to double that to 40,000 over the coming weeks, providing increased provider education, removing barriers to get more into the pipeline, and to increase the knowledge and awareness on the parts of providers and patients for the use of Paxlovid oral antiviral and Molnupiravir as well. Next slide. So as we are continuing to move into kind of a more sustainment phase of the pandemic, coming down from the kind of crisis emergency response phase that we had in the Omicron surge in January, really where our cases bottomed out, starting to see that slower, gradual increase, but manageable, not disrupting society and lives like this was before. We're moving to more of a sustainment phase, and you're starting to see that echoed across the country with other states. We've kind of been in this process for a while. CDC is kind of moving its response capabilities back to their home programs, and scaling down its incident command response. In Indiana, we have developed a sustainment plan for that transition phase. While we want to make sure that we have the ability to scale up and respond, but also we want to right size that to make sure that we're managing resources well. So we've developed our Right on Track plan. Track is an acronym. We have lots of those in public health that stands for several things. The T in track is maintaining our testing and treatment, ensuring that folks have access to over the counter tests. We've distributed those through schools and local health departments. We're expanding access to treatment like the oral antivirals, the monoclonal antibody treatments, as well as the monoclonal pre exposure prophylaxis, Evusheld. Therapy, and educating providers and the public of the importance of testing and treatment, and really linking up testing and treatment through test and treat sites. The R in track stands for readiness, maintaining our personal protective equipment stockpile here at the state level, and being prepared for the next response and updating our emergency plans with the lessons that we've learned through COVID-19 response to maintain that readiness, not just for the next COVID-19 surge, but for any large scale infectious disease outbreak. The A in track stands for awareness, updating our data dashboards like you just saw, and making sure that we are issuing information that will inform and enable Hoosiers to protect themselves, as well as coordinating our state and local recovery efforts, making sure we're aware of what's happening on the national level with updated recommendations and guidance. The C in track stands for community resilience and countermeasures, addressing health inequities that we've seen really exacerbated through the pandemic, continuing to promote vaccine and not just COVID-19 vaccine, but those routine childhood vaccinations that took a hit during the COVID-19 pandemic. And we've got kids now that are unprotected or not as protected as they should be because they've fallen behind in those routine childhood vaccinations. We are currently developing a plan for an initiative to catch up children with those routine childhood vaccinations so that we don't have outbreaks of vaccine preventable diseases. Nobody wants that. Also, making sure that we have the information and the supplies for additional non-pharmaceutical interventions to reduce the risk for vulnerable populations, including our long-term care facilities, our healthcare settings, our congregate settings, and then making sure that we engage communities to lower any vaccine hesitancy and identify needs that they may have. Finally, the K in track stands for kids, promoting a healthy in school environment, utilizing partnerships that we have to be able to distribute at home tests, to be able to assist schools with isolation guidance, and then catching up those children on the routine childhood immunizations and preventive health screenings. Next slide. Our surge planning here at the state level includes ensuring adequate supplies of personal protective equipment are available in our stockpile, including masks, NIOSH approved respirators, ensuring that we have adequate testing supplies readily available, including a method to anticipate and calculate our daily PPE usage or burn rates, and anticipate changes that may occur related to a surge, ensuring compliance with infection control procedures, and that includes updated staff trainings on what is the latest guidance for PPE or isolation or disinfection or ventilation. Ensuring and promoting proven COVID-19 mitigation and control measures, which you can see posted at the link on your slide. Next slide. Also ensuring compliance with the federal reporting requirements for bed capacity and therapeutic usage, ensuring that we maintain access to therapeutics for staff and patients in our healthcare settings, and ensuring equitable continued access to vaccine for all Hoosiers, since that is such a linchpin tool to prevent COVID-19 infection. And we here at the Department of Health continue to have free PPE and testing supplies available for acquisition. And now I would like to turn the program over to Jeremy Turner, who is our director of our HIV, STD, and viral hepatitis division. Jeremy entered the field in 2004 as a community health educator and grassroots HIV activist. His experience with homelessness at age 17 shaped his passion for working with marginalized populations, both medical and supportive services being addressed, and the needs that folks have, while acknowledging that social determinants of health play a vital role in achieving successful health outcomes. During his time in the field, Jeremy has worked across the entire spectrum of HIV services, including prevention and testing, housing, case management, development, and communications before transitioning to serve as a deputy director of our division here in 2017. And then in August of 2022, Jeremy will be celebrating his 18th year of public health service. So, Jeremy, take it away.
Thank you so much, Pam. It's great to be here today. We have a fantastic informatics epidemiologist that was supposed to be presenting today that had some family issues pop up. And so you guys have me here instead. I hope that talking about HIV and STDs is a little nice break from focusing so much on COVID-19. I know that after I was done helping to respond to COVID here in Indiana, it was nice to come back and dig into the work that we do. If we look at our first slide today, I just wanted to provide an overview for how our division is structured. We've undergone a new strategic plan that had us realign how our services are divided within the division. Formerly, we were in disease silos that did not have our teams working together with folks who have the same talents. And so now we work under four different pillars in the division that help us address the needs of the people that we serve. Next slide, please. As we move forward, taking a look at our statewide ending the epidemics plan. In 2019, Indiana did a statewide needs assessment to help understand where we needed to apply resources. And then in 2020, we did a year-long planning effort so that we came up with this. This is the branding around zero as possible, our statewide plan to end HIV and hepatitis C. Next slide, please. The Zip-In has four pillars that are the national pillars for ending the HIV epidemic: diagnose, treat, prevent, and respond. And then we have some cross-cutting strategies that we've learned through all kinds of different ways that we've collected information from people with lived experience and through surveys that were conducted with healthcare providers that really focus it around eliminating stigma and then incorporating and making sure that we have active, meaningful involvement with folks with lived experience to help advise on what we can do to build a system of care that works for the people who need it most. Next slide, please. Zip-In is a coalition-based model. The ZIP coalitions represent a coordinated community-based approach to identifying needs, building a system of supports and services to address those needs, and collectively monitoring progress and working together to strengthen the system to meet the needs of all community members. They are responsible for leading regional efforts to end the HIV epidemic and eliminate hepatitis C while also addressing the STD burden that we have in our state. And they include engaging diverse partners, especially those people who have been impacted by HIV and hepatitis C, and using data information to set priorities and act strategically. Next slide, please. There we go. This is a dashboard. I wanted to make sure that we presented this information to you. We are working with local communities to provide data so that people can make data-informed decisions about their approach to care and services. We have all kinds of tools that we use to work to tailor these reports so that people are able to see, service providers are able to see what the prevalence of disease looks like in their area and slice and dice the information in ways that help them to reach out to these specific priority populations that are disparately impacted. This is just a representation of new cases in Indiana. We continue to see about around 500 folks a year diagnosed with HIV. One of the things I think is really good is to highlight that that number of people who are at first diagnosis are found to have HIV and not AIDS increases, and our number of new AIDS cases or AIDS at first diagnosis continues to decrease year over year. That's really good for a variety of reasons because it means that we're reaching people sooner. But we also know that if we catch people before that they have an AIDS diagnosis, that they have better health outcomes throughout the rest of their life. One of the things that we also wanted to highlight in this presentation is this table showing each person living with HIV by their race and ethnicity. By number and percentage, whites are considered to be the majority of people living with HIV in Indiana. Although blacks represent a smaller portion of the overall population, they are shown to have the highest prevalence rate among all group. Those represented as being of Hispanic origin have the second highest rate. And so one of our big cross-cutting strategies is to understand how we can work to eliminate these health disparities among these disparately impacted populations. This is our HIV continuum of care. This is something that we're extremely proud of. This shows the number of new diagnoses that we had in previous years, and you can see that our HIV prevalence continues to go up. It's really important, though, that we continue to see that number rise, because that only represents about 87% of people living with HIV who know their status right now. And one of the first steps to ending the HIV epidemic is making sure that as many as people who are living with HIV know their status, so that we can enroll them into the care and services that they need to have good success with their health outcomes across the other stages of the continuum. You'll notice the next phase of the continuum is linked to care within 30 days. This number is always going to be artificially low because it goes back to as long as we've been tracking the information, and the measurement has changed over years to now where we are only counting the measure of success being linking folks within 30 days of their HIV diagnosis. And while that number remains at 56%, we are now reaching 90% of people living with HIV linked to care within the first 30 days of their diagnosis, which is a huge success for us. The number of people retained in care, or the number of people that we are receiving regular reports of their HIV viral load, has increased up to 76%, which is a big increase in 2021 from the previous year, as is the number of people who have reached viral suppression, up to 68% in 2021 versus 64% in 2020. To talk about syphilis during today's presentation as well. While we've seen some really great improvements with HIV, coming out of the COVID-19 peaks of previous years, we're noticing a rise in STDs of all kinds across the state. But syphilis is really a major concern of ours. In the past in Indiana, people who have been most impacted by syphilis, as you can see in the representation here, have been men who have sex with men, or people who identify as gay or bisexual. But we've seen an increase in numbers among heterosexual men and women over the last 5 years. And in particular, in another part of our specific part of our state, rather, in southern Indiana, we've had a syphilis outbreak, which has primarily impacted heterosexual folks. And I wanted to spend some time during today's presentation to highlight what we've been seeing, how we manage the data, and how we're continuing to track this across other communities in the state that are starting to have some warning signs where we may see this impact other folks here in the future. This is just a representation of the different stages of syphilis and how our outbreak tracker manages this information. We have a great team of folks here who are compiling all of this information. And what we're looking for are standard deviation differences that trigger us to be in warning phase or an outbreak phase, and then trying to understand where we're catching folks in their syphilis diagnosis. This is an example of the outbreak tracking dashboard that we use. And as you can see here, we're trying to make sure that we are looking at this from a variety of different perspectives. We have folks who are constantly working with disease intervention to interview cases, to understand where they're meeting partners, what kind of risk factors are involved, understanding the demographics and the risk behaviors of the population that we're working with. You can see in the Southern Indiana, the District 8 outbreak, that we have all kinds of different measurements that are available that we're supplying to people on the ground so that they can direct their community outreach efforts. These populations that are being impacted are traditionally harder to reach folks, people who are in active substance use, people who have a history of homelessness or incarceration. And so as much information as we can provide, we try to put out there so that we can effectively get these interventions in place to catch people in infection as early as possible so that we can prevent the spread of disease. This is just a little overview. Every county in District 8 has been impacted by this syphilis outbreak, but we have not yet seen other counties outside of D8 impacted. We can track this all the way back to June of 2021. As of the date of this slide, we had 120 cases. We're up to 122 now. 7 of these folks were pregnant, and 63 of the cases were either primary or secondary syphilis. And we did have 1 congenital syphilis case linked to this outbreak, but we have also seen a troubling number of congenital syphilis cases statewide in other portions of the state. We did see 11 hepatitis C co-infections, 2 hep B co-infections, 1 person with hepatitis A, and then we did identify 5 new folks with HIV or folks who were not previously virally suppressed. As I mentioned a little bit earlier, these are some unusual risk factors. So the D8 situation was impacting folks that we haven't traditionally been targeting with syphilis messaging because they had not been disparately impacted before. But the grand majority of people involved with the D8 outbreak had a history of homelessness, exchanging sex for drugs or money, injection substance use, particularly methamphetamine use. They were meeting their partners online with social media, and this was using like Facebook or Instagram. People who had been previously or who were currently incarcerated, and then folks who were injecting with people who resided in or around Evansville. We love to work with people to tailor the information that we have. We collect all kinds of information around the testing that we do and the services we provide. If you're interested in learning more, we have great folks who work with all of the data that we collect that we can custom make reports so that you can use that to inform decisions that you need to make in the provision of services, regardless of where you live in the state. So please feel free to reach out to us anytime. We are here to serve. I know that was a rat race. I was trying to make sure that we left plenty of time for questions at the end.
Well, thank you, Pam and Jeremy. At this time, I think we'll take some questions from the audience. Just a reminder, the question and chat box is located on the right side of your screen, or you can ask questions through your phone line or computer microphone. Dawn, do we have any questions submitted through the chat?
We do have one question already in the chat from Mandy Williams, and it's a question for Pam Pantones. Asking, do you have a sense of if or when the CDC may begin recommending second boosters for individuals under the age of 50?
That is a great question, and thanks for asking, Mandy. I've not heard anything yet, and CDC right now is still with the using the language of can or may for individuals even 50 and above to get that second booster. That's not necessarily a should or a recommendation at this point. It's a choice that folks 50 and above can get those second boosters based on their health history, their risk, consulting with their healthcare provider. But that question and then question for second boosters for individuals under age 50, we may hear more about as we start getting through some of these other points of discussion with FDA, VRBPAC, and as we go forward closer to the fall and the June 28th meeting of VRBPAC, you might see that change. That would be my sense right now, is that we would hear more about that as we get closer to the fall. But currently not hearing anything about second boosters for individuals under age 50, and still at the may can thought for individuals 50 and over.
Okay, Mandy said thank you for clarifying. And Tammy, I don't see any other questions in the chat right now.
Okay. Such great information today. Just once again, want to encourage folks, if you have any questions at all, please feel welcome to put those in the chat. Our speakers are here and ready to answer questions and just kind of discuss other things that you may be interested in hearing about. If there are some topics that you heard today that you'd like them to go into maybe some deeper detail in the future, please let us know. We want to hear from you.
Randy, I would like to add some really exciting things that we didn't have in the presentation today, that while we have some folks on the line who might be non-traditional partners, a big portion of our Ending the Epidemic strategy engages folks that haven't been a part of what we're doing up until now. And so at this point, when I say that we have about 87% of people who know their HIV status, identifying people who are status unaware at this point is getting to be like losing that last 20 pounds. So if folks have a lot of weight to lose, it's really easy as you get lifestyle change, to drop a significant portion of weight earlier on. But then as you get towards the last little bit, that can be the hardest. And so that's kind of the analogy that we use when we talk about these last folks with HIV that we're trying to identify. And we have some really great and easy diagnostic tools that are available. And I don't know that everybody's aware that we have a 1-minute rapid response HIV test, which is a great tool that can be used at point of care. It can be used in outreach settings. We talk about our syphilis outbreak and our syphilis outreach that's been going on. We have a 10-minute rapid response syphilis test. And so, and then the hepatitis C rapid test is a 20-minute rapid test. And so essentially, in 20 minutes, we can have someone tested for HIV, syphilis, and hepatitis. And that can be conducted, during the outreach we were doing in Evansville, we were doing testing on people's front porches in high prevalence areas of town. We were doing testing in the back of bars and nightclubs, all those kinds of things. So we have other resources, pre-exposure prophylaxis. Pam referenced this in relation to COVID-19. But PrEP is a fantastic biomedical intervention that we have to help prevent the spread of HIV, just as effective as condom use at preventing HIV infection. So we have these new tools that make all of our work so much easier than it was years ago, when you had to wait for 2 weeks sometimes for a lab result to come back before you knew someone's status. So we really have the tools to end the HIV epidemic, and these are not new tools, and so we need everybody that we can to come to the table and help us learn how we can apply them so that we can accomplish our objectives that we have in these great plans that we've done. And I'm so impressed with Indiana and our approach and what you see represented. I appreciate Don sharing the plan website. Is really the result of what Hoosiers have told us, because we're not going to end the epidemic at 2 North Meridian in downtown Indianapolis. We are the people that shuttle the resources out to the folks who are actually providing the services that are going to make the work happen. And so thank you guys so much for your interest in this. And I look forward to, if anybody wants to get engaged with us, like I said, this is a coalition-based model. And regardless of where you live in Indiana or what type of service provider you are, there is a place for you in our Ending the Epidemic plan. And even for folks who are long-term care providers, if we dove a little bit more into the information around people living with HIV, we have an aging population. I attended a breakout session recently where we had a medical provider who said they never thought that they would be talking about geriatric AIDS. But we're in a place in time now where, although the majority of new infections are happening among people who are under 40, the majority of people living with HIV are over 40. And then we have folks who were infected at the beginning of the epidemic, in the early 1980s, who have been HIV positive for 40 years now. And the complications that they've had from the early treatment options that were available to, the comorbidities that they've developed, and then just the issues that come along with folks aging in combined with their HIV infection, we're dealing with all kinds of interesting concepts and approaches to care that make sure that they stay virally suppressed and they live full, long, healthy lives that are not impacted by their HIV infection. So all kinds of great things. I could talk for forever about this, but we just did a little tip of the iceberg talk for our initial conversation today.
Thank you, Jeremy. You've kind of done a nice segue. I was going to ask Dr. Bupalanchi if she wanted to speak to that point, as far as long-term care, or anything else we've talked about today, but see if she wanted to expand on some of what you were saying as it relates to folks in long-term care.
Right. Yes. Thank you, Tammy, for that opportunity. I was wanting to make a comment. So, first of all, I want to thank all of you who are on the call today for the great work that you have been doing on COVID and otherwise. And the last couple of years have been rough, and you held on and doing a great job. So, thank you. So, I'm just going to basically summarize what both of them have said. Now we have more knowledge about COVID and how it spreads, how we can contain. So, keep in mind infection control practices. We have vaccines. We have Evusheld for people who cannot mount a proper response with the vaccine to prevent infection from happening. And if infection does happen, we know how to stop the spread. So keep those in mind. And then we have antivirals, and we have bebtelovimab, and so just keep those in mind and keep up the good work that you're doing. And as Jeremy covered, now keep in mind, if you see a patient or a resident that has some risk factors, consider having the discussion about offering the test, and if you need the tools and how to do it, just reach out to us. We'll be more than happy to help. There are, again, fantastic treatments for HIV. 20 years ago when I was in residency, majority of the people died young, and there were medication treatments that were not very easy to take. They were complicated. People could not tolerate, and lots of super infections, opportunistic infections, those kind of problems. But now the medication regimens are a lot simpler. There's much less stigma. Actually, if you see people in the regular community, you cannot tell that they have HIV or AIDS, because the medications are wonderful and they are doing really well. And as he mentioned, people are living long. And just like any other condition, you have an infection that is chronic, but you can take it and live a normal life thereafter. So if you come across anybody that might have some kind of a risk factor, please have the discussion, and get them tested and those kind of things. So definitely science is evolving, and you guys are doing a phenomenal job taking care of the patients at the ground level. And thank you.
Dr. Vupalanti, one of the things too, to just, add on to what you said, is that not only are people having great success with the treatment options that were available, that you don't have to be an infectious disease specialist to be the provider of these services. We have excellent programs that we fund through the State Department of Health for both hepatitis and for HIV. I am sure a lot of you are familiar with the ECHO programs that exist out there, but the HIV ECHO project and the hepatitis C ECHO project are specifically geared towards providers of care. And you don't have to be a doctor to participate, or a medical provider. You could be a clinical social worker or a therapist. We have a multidisciplinary team of Indiana's top experts in this field, who are available as a resource for free, where you can send in specific, de-identified case information to review with the best providers of service that exist here in Indiana. The doctor who sits in on these is like our version of Dr. Fauci. I like to call her Dr. Bree Weaver. We have, an LCSW from IU Methodist, who has literally been doing this since the beginning of the HIV epidemic in Indiana, and can really provide some great approaches to those supportive service needs and those social work needs of our patients that we serve. So if you need more information about the ECHO programs, it's a great way to make sure, because I come from Southern Indiana. I always am, from the hills and hollers of Indiana, and you could be a nurse practitioner, a PA provide just the same level of effective infectious disease care for folks living with HIV as our top disease experts at this point, because it's not as nearly as complicated as it was in the earlier days.
Okay, thank you, Jeremy, and thank you, Dr. Vupalanchi. Pam, any other thoughts or things you'd like to share before we conclude our call today?
Thank you so much, Tammy, and just would like to say thanks so much to all of you for spending an hour with us today. I really appreciate your time and attention. Hope this was helpful for you. We want to be able to provide information not just on COVID-19, but other public health issues that are helpful to you in your daily work. We heard that you wanted to hear more on HIV and STD viral hepatitis, so we wanted to invite Jeremy and folks from his team to speak with you today. We also have a good lineup for you in June as we discuss more on antibiotic resistance, Candida auris, and some of the parameters around those that you might encounter in your daily work as well. So certainly wanting to hear whatever topics that you feel would be helpful for you at this point. We will continue with our COVID-19 updates because we will be seeing more from FDA, more from CDC on vaccine rollout and where we might be headed for the fall. So we'll be sure to keep you informed on those, but would also love to hear more topics that you would like us to share with you that would be helpful to you. So again, just thank you all so very much for your time and attention and for our partnership with QSource. Folks are fantastic.
Well, thank you, Pam, right back at you and your team there at IDOH. We really appreciate the partnership, and we always look forward to the monthly presentations, I think, as much as our attendees do, because we always walk away with new information we didn't know. So, so greatly appreciate and thank all of you and everyone for joining the call today. Once again, know that everyone at Indiana Department of Health, as well as the QSource team, we're all here to help you and answer any questions you might have, anything that you may have heard today, or if you're needing any sort of, technical assistance with quality improvement initiatives, we're all here to help. So we do have one more polling question for you to kind of gauge your experience from today's event. As Pam shared, your feedback is so very valuable to us, and it helps us shape future events, because we want to make sure we're sharing information with you that's meaningful. So on a scale of 1 to 5, where 5 represents very satisfied and 1 represents very dissatisfied, we'd love for you to just indicate your level of satisfaction with this session. So as you're completing that, I want to thank all of you for completing that poll, and thank you for providing your feedback. If you weren't able to participate on this polling question for some reason or another, please know that QSource will be sending out a follow-up email. It will include not only the slides from today's presentation, but also an opportunity to provide some additional feedback, like what you liked about today's presentation, suggestions for improvement, as well as topics for future events. Okay, our poll is closed. On this slide, you'll also see some additional ways to connect with us. In addition to attending these webinars, you can also connect with QSource through Facebook, Twitter, and LinkedIn. Once again, I want to thank everyone for joining us today. We look forward to having you join us again during the June Public Health Update. Pam shared with you a little sneak peek of what you will hear next month. And I want to wish everyone a great afternoon. Thank you.